Regarding the ratio of products transfusion, there has been randomized trial which has been done, that is a proper trial where they looked at 2:1:1, that is 2 units of PRBC along with 1 plasma and 1 platelet versus 1 PRBC, 1 plasma, 1 platelet. So if you look at the outcome in the study, the 24-hour mortality or the 30-day mortality or the number of bleeding complications are much less when you are transfusing 1:1:1. So even in the pregnant population, we all know that pregnant physiology is so beautiful that during the delivery or the labor, that there is a lot of anticipated blood loss. The body tends to increase the coagulation factors to prevent the bleeding. That is physiologically what is happening. When such a pregnant mother is losing a lot of coagulation factors, the ratio of the coagulation factors should be corrected. So 1:1:1 still holds good in pregnant population.
So the add-on point is, in resource-limited country like India, where the packed cells may be available, but your FFPs and RDPs may not be available so frequently, this particular study has given a clue that even though 1:1 may be an ideal, the bleeding tendencies were less, the mortality between them are comparative. So in a resource-limited setting, 2:1:1 also holds good if you don't have a 1:1:1. As expected, these patients were transferred to us on multiple vasopressors, NORAD 30 ml, adrenaline 15 ml, vasopressin 2.4 ml, and in initial CBC sample, which is a point of care test, talks about a very low hemoglobin, low platelets, and coagulopathy with high INR and APTT oozing from everywhere. Vinita ma'am, it's a very straightforward answer. Okay. It's not the PPH who kills the patient. PPH is a treatable condition, you replace the blood. This is what kills the patient, ma'am.
This is DIC, so she's already in DIC clinically because she's oozing from all the surgical sites and IV lines. And also the values that you have provided, there is International Society of Thrombosis and Hemostasis criteria for DIC. That also states if the platelets are less, INR is more, PT-APTT is prolonged, and if we have FDPs and fibrinogen, that adds value, and all these are already telling that the value is more than 5, it is over DIC. So diagnosis is clear.
Yeah, so this is a very straightforward diagnosis, and it is the final point of the death. If you see any of your case who is dying, this is the final point of, and here comes the trick. OBG's clinician says, see, it is a DIC oozing everywhere, I'm not going in. You please take care, you correct your products. We say, ma'am, it's oozing everywhere. You go and look at inside. He said, if I open, it will bleed more. And this debate will go on. Is not that true? And at the end, most of if we are not acting, and we lose them. And there is a change happened in the last 10, 15 years. And that's where Dr. Nikhil comes. He doesn't open, but he takes care of the bleeding. He knows there is a raw area, so I will not go as a surgical option, but he takes care. Nikhil, how do you handle these cases?
So as we have been already discussing, so any incision in this patient will lead to further bleeding. So this is one such patient. This is the CT image where we can see that bilateral, there is a rectus sheath hematoma. And you can see there is a differential density, which means to say that there is active ooze that is still going on. And if you can see in the third image and fourth image, which is the post-contrast images, there is active bleeding that is going on in these images. Sure. And also the patient had active PV bleeding. And even though these patients are in coagulopathy, only the incision sites are bleeding. It is not that she's bleeding randomly from some different sites. So we can go in selectively, either from the radial artery or the femoral artery. And most of the times for arterial BP monitoring, we already have an arterial line access as well. So these patients, we can safely go in from the radial artery approach. This is the right external iliac artery angiogram where you can see the inferior epigastric artery. Next slide, please. And this is the inferior epigastric artery selective angiogram. Next slide. And you can see that there are multiple points of active extravasation, so which are marked with blue arrows. And since these are multiple site diffuse ooze, we go ahead with particulate embolization with particles. Next slide. This is post-embolization, where we see that the bleed has stopped. Next slide. And do we stop there? No, we wouldn't stop because the patient had diffuse ooze. There was also PV bleed. we empirically block the contralateral inferior epigastric artery as well as the bilateral uterine arteries selectively with the help of microcatheter and particles.
So what generally happens in this point of time is many of us, we were discussing and debating why epigastric artery is opening up and others. I feel in normal circumstances with intact coagulation cascade, most of them will not bleed. Okay? When you are in a terrible DIC with severe coagulopathy, dropped in thrombocytes, extreme coagulopathy, every side start bleeding. And even though there is a DIC, the common areas are raw areas, which has undergone surgery. So we have somebody who comes in between and saves us. And in this situation, when there is a diffuse ooze after all this, we keep on actually looking for, do I need to give platelets? Do I need to give FFPs? Do I need to give cryos? Or do I need to give antifibrinolytic agents like tranexamic acid loading or infusion? Dr. Ravi, what is that we use to actually identify what product will be helpful?
So conventionally, we are all very well versed with, routine coagulation parameter monitoring, that is your classical PT, APTT, INR, and your fibrinogen, one which looks at the intrinsic, the other looks at the extrinsic pathway. Then we are also looking at the fibrinogen level because we are looking at the DIC picture. But unfortunately, most of this test doesn't tell you what is the product which is required for the patient. So if you ask me, 9 out of 10 times we give empirically. Fibrinogen is low, you correct with cryoprecipitate. INR is high or APTT is elevated, patient is bleeding, you give FFP. Or if the platelets are, you put a target more than 50,000, if it is going below the target, then you start correcting with platelets. But if you are fortunate to have a viscoelastic testing, that is the dynamic, clot mechanism, what we are looking at, the point of starting from the platelet plug formation to the formation of the clot and the clot lysis mechanism. So we exactly understand where is the problem. If you look at, we have two, conventional viscoelastic testing methods, that is a ROTEM, that is a rotational thromboelastometry, and also the thromboelastogram. Functionally, they are slightly different, but whatever we are looking at interpretation is the initiation of the clot, the maximum clot amplitude, and the clot lysis mechanism. If you know that this is hyperfibrinolysis, you want to selectively block that. So the role of tranexamic acid comes there. Or if the problem is with the amplitude of the clot formation, there you understand that the problem is with the fibrinogen, I will selectively use cryoprecipitate. But if the problem is with the clot formation itself, then that is a place where there is a role of coagulation factors, either as a whole complex of FFP, or now we have prothrombin complex concentrates, or you can replace, if you are equipped with selective factor deficiency, then you can replace the individual components.
So as we understand, DIC platelets can actually add fuel to the fire, which we know disseminated intravascular coagulation. It can actually consume your other available product. So this viscoelastic test will tell you whether you need factors, that is clotting factors like FFPs, or you need fibrinogen, you need platelets, or it is lysing very quickly, you just need a tranexamic acid, load and put infusion, and that will take care of rest. So this is an add-on test. I do understand it may not be available everywhere, but this can give a clue to you. So with this, I think the take-home message which we actually face in this case is, you should anticipate that every case can be a PPH. You should have a massive transfusion protocol in place, and there should be a way and mechanism to use. Do not forget tranexamic acid can be useful. The blood product ratio is 1:1:1, or in extreme situations where there is a limitation, so you can use 2:1:1. And viscoelastic test can be a useful tool if you don't have any facility to actually intervene. Interventional radiology, please take a help of interventional radiologists available in nearby centers. That I think summarizes all in this point.